Good afternoon. Thank you for joining us today. We're in a session on lowering the price of dementia, innovative solutions to reduce risk. So if you meant to be on another airplane going somewhere else, it's time to depart now. We have many others out in the back waiting to go in because this has been such a hot topic for people to discuss. So we're really delighted to have you here today. I'm going to start with a few facts just to put this into, let us understand where we are with this. So right now there are about 5.7 million people living with dementia in the US, and by 2050 that number is projected to triple to 16 million. What we know too is that according to the Alzheimer's Association, informal caregivers of people with dementia provided 18.5 billion hours of care in 2018 in the US alone, with an estimated economic value of $235 billion, that's billion, dollars. So we're going to start on sort of the sad side. What are the challenges? Where are we? But all of us here also are very hopeful about where we're headed. And so we want to leave you with some thoughts about what we're learning in the science and policy and working in communities and integrating health and long-term services and supports to get us to a better place for people living with dementia, those at risk for dementia, all the people that love people who are at risk for dementia, which is everyone who's in this room, right? So we're really glad to have you here. I have a great panel, and we want to make this as conversational and as interesting as possible for you all. So we're just going to ask some questions. I'm going to just introduce them by name and title, which doesn't give credit to all the many things all of them have done in their careers. So if you want to learn more about them, just check out our program. It's there. So all the way to my right is Norma Coe. She's an associate professor in the Department of Medical Ethics and Health Policy at the Perelman School of Medicine at the University of Pennsylvania. Then next to her is Linda Elam, who is the CEO and plan president of Amera Group, District of Columbia. Next to me is Dr. Howard Fillett, the founding executive director and chief science officer of the Alzheimer's Drug Discovery Foundation. And certainly, last but not least, George Vredenberg, who is the chair and co-founder of Us Against Alzheimer's. So when we listen to and think about the prevalence of Alzheimer's, how it disproportionately impacts women and people of color, I want to ask each of you, from your perspective, what keeps you up at night? Norma?
All right, thanks for having me here. So I spent the last few years basically estimating the cost of Alzheimer's and dementia in the United States. There's a lot of attention paid to how much it costs Medicare. But, honestly, it's not that much money. Our estimate suggests it's about $3,000 per case. Sure, if you add it all up, there's a lot of cases. But really, people don't fear Alzheimer's because it's of its high healthcare costs. This isn't cancer. People fear Alzheimer's because of the cost it is on them and their families. And so as an economist, what I've spent a lot of time thinking about is how do we actually estimate what families are doing for people with Alzheimer's. So 80% of people with dementia are living at home and being cared for because of their family and friends. Like Nora mentioned, that's 17 to 18 billion hours, and none of that is accounted for when you think about the Medicare costs. So if you think about it from an economist perspective, you think about, first there's just, you change what you do with your time. You're now taking care of your parents. Maybe small things in the beginning where you can't go to dinner with your friends because you're doing something for your mom, or you can't go on vacation because you can't leave mom unsupervised. No money is actually being exchanged, but that actually fundamentally changes your happiness and your well-being. And so as an economist, what we do is put a price on that. We know that caregiving also has health implications with increased depression and anxiety and increased physical disabilities due to caregiving. And then the non-trivial cost of really is that, eventually you need to do something for your parents. That means that you're taking them to the doctor, which conveniently is open 9 to 5, Monday through Friday, the exact same time you're supposed to be reporting to the office. Right? It means that you need more flexibility on your job. That comes at an immediate cost with lower income today, wages stagnating, but also in the future. You may need to switch jobs or leave the labor market altogether. As a 50 to 60-year-old woman, the average caregiver in the United States trying to re-enter the labor market after a caregiving stint, which is on average 4 years, I wish you the best of luck. Our estimates suggest there's about a 3% chance you're going to get an offer for a full-time job, 15% chance offer for a part-time job. So if you add all of that together for the caregiver, the cost is about $80,000 to $100,000 for the median caregiver in the United States for a woman taking care of her mom. That's why people dread Alzheimer's and dementia. It's not about what's costing Medicare. So what worries me in the future is that we have this heavy reliance on informal care and an unsustainable reliance on informal care.
Great. And George, we've had the opportunity to work with each other over the years in Us Against Alzheimer's. And one of the things that the Milken Institute did in 2016, before I came here, was a paper that was really a seminal report on the price women pay for dementia. It was looking most strategically at ways to ease gender disparity and economic cost. I know, as Norma was saying, one of the issues with women in particular is not only their increased risk, but that they're the ones who often take time out of the workforce to care for family members, which then impacts their income at later stages of life and makes them more financially insecure or have some health issues. I know at Us Against Alzheimer's, you all have also focused, and we're going to work together to update that paper, focusing not only on more what we know about new strategies, but also what we know about minority populations. So when you think about the prevalence and where we're headed what keeps you up at night?
Well, the chief problem is here, if we get a drug, only the top 10, 15, 20% of the people can be able to pay for it, because Medicare right now is resisting paying for any of these drugs until their actual impact on real-world populations is calculated, which could be 5 to 10 years after a drug is approved. So that would reach a certain segment of the population, but not a great segment of the population. If we talk about lifestyle changes, which I know you want us to talk about in a few minutes, we're going to talk about people who basically are in the upper quadrant of the population again. So what keeps me up at night is that there are whole segments of this population, in part women, who probably bear 75 to 80% of the cost of this disease as a gender. Sex-based differences in the disease are prominent, but not yet adequately studied. In communities of color, blacks are up to 2 to 3 times as likely to get this disease as whites at the same age and the same condition. Latinos about 1.5 times as much. People living in low-income communities and in low-income families are much more likely to get the disease. So this disease, even if we solve it with what the tools are that we may have sometime in the not-so-distant future, is that we're going to leave out significant segments of the population, and we will drive income disparities, we're going to drive health disparities, and we're going to drive gender disparities big time. And so we've got to figure this out for all Americans, and not just those who can afford private pay, or just those who can afford a Fitbit and all the accoutrements of a lifestyle change.
Howard, as a geriatrician, I know you have your specialty is working with older adults. As you think about the prevalence of dementia and where we're headed, what keeps you up at night as a geriatrician?
Yeah, I've been taking care of people and their families with Alzheimer's disease for about 40 years now. And I frankly haven't seen a lot of changes. People really require a lot of appropriate diagnosis, early diagnosis, care management, education and counseling. And they're not getting it. I mean, when the average physician visit in the United States is about 11 minutes, I tend to spend an hour or an hour and a half with patients, and it's not a sustainable practice for any doctor really to do that. So I often get referrals, for example, from people who've seen neurologists, and they say, well, the neurologist told me I have Alzheimer's or I have dementia, but I don't know the difference. What's the difference between Alzheimer's and dementia? We've been trying to educate people about that for.
Can you just give them for people here that may the elevator speech of the difference? So.
Well, Dementia is a term that describes the patient. It's basically sort of like saying somebody has anemia. Somebody comes into the office and they're pale and they're weak and they have a low blood count, and we say, you have anemia. And then the next thing you say is, well, gee, why do you have anemia? Are you losing blood from a colon cancer or something like that? So it's sort of the same thing with dementia. So we have clinical criteria. It involves cognitive impairment in more than 2 domains. That's severe enough to cause functional impairment. It's not caused by things like depression or polypharmacy or other thyroid or B12 illness problems. And it's basically, generally speaking, a rule-out diagnosis. So we say somebody has dementia, and the next thing we do is we try to discover what the cause of the dementia is, and about 70% of the time, it's Alzheimer's disease. Thing is, I often get asked, like, why bother making a diagnosis of Alzheimer's disease or even dementia when there's nothing you can do? And we faced this when we helped to bring the first FDA-approved diagnostic test to Medicare. It was approved as safe and effective. It's a brain scan. It's a PET scan. In the old days, when I wanted to make a definitive diagnosis of Alzheimer's disease, I kind of did it on a clinical terms, the way I just described it to you. But today, if I see a patient in the office, I can write a prescription for a radiology exam. They can go right down the block in Manhattan, and they can get a PET scan, and I can tell them with 98% certainty within about 24 hours whether or not they have Alzheimer's disease. And this, I find this can make a big difference. And there was, when the test came before the Medicare Payment Committee, it wasn't approved because people had this nihilistic, people on the committee had a nihilistic view of why bother to make a definitive diagnosis. And I don't know of any other field in medicine where this kind of nihilism about diagnosis and the ability to prognosticate exists. So what Medicare did, and it kind of alludes to what George was saying about payment, although I disagree a little bit about one thing, but what happened is Medicare went out and funded a study of almost 19,000 people where they enabled doctors who were dementia experts to get this PET scan on people and see how it changed their diagnostic certainty. And it turned out that 50% of the time doctors were wrong in making the diagnosis of Alzheimer's disease, and 60% of the time this had a big impact on care and treatment. But again, we don't know what's going to happen with that test at this time. But I think it's a prelude to what you're going to see going forward. We started this diagnostics accelerator.
So if I can interrupt, because I want to get Linda into the conversation, and we'll talk about early diagnosis. Sure. We'll talk about many of the things we're doing in the community. But Linda, I know you're an expert on long-term care and our lack of a system in the U.S., how, and many of the things Norma said about depending on informal care, I know has been a research focus of yours. As someone who's been the Medicaid director in Washington, D.C., and been on the ground with some of the most vulnerable populations, when you think about the prevalence of dementia and what we have going, what keeps you up?
So it's 2 things. One is very much a health systems issue, and one is very much a person issue. The health system issue is that we don't have an adequate long-term care system in this country. And it's not widely appreciated by folks that there is not a long-term care benefit of any significance in Medicare. Medicaid is the primary payer for long-term care services in our nation. And Alzheimer's and related dementias are key contributors to the use of long-term care, whether it's in a facility or care at home. In the absence of some sort of really significant change to how we finance long-term care, the kinds of income inequality that the other panelists have discussed will only increase. So our sort of lack of ability to grapple with this already enormous problem that's only going to grow will impact all of us, and in particular, those people who are least able to bear the financial burden to take on caring for a loved one with Alzheimer's disease. So and as a former Medicaid director, I can tell you, people look at Medicaid as this huge part of state budgets that's taking over from everybody and eating up, all of the resources. But again, they're not recognizing all of the roles that Medicaid it plays for the population. This will only make Medicaid as an entitlement program expand, creating more difficulty within state budgets and more pressure to cut. So, we have a health system issue that will, if left unaddressed, only exacerbate income inequality, which is disastrous not just for the people that it impacts directly, but for population health overall.
Great, and so now I really want to open it up to everyone. I said, please interrupt each other, contradict each other. I mean, you can argue with each other. We want to keep this lively for the discussion. We ask that you, of course, be respectful.
Should we stay in our chairs, though?
Stay in your chairs, that would be good. But so this question of sex-based differences, I want to turn to the scientists here about, what do we know about the sex-based differences in terms of the risk for dementia in there. The NIH hasn't been studying the differences of men and women for very long and have been doing it more. So what do we know now?
Well, for all of us, we know that our bodies are gender differentiated, right? So men and women look different, and we have structural differences in our bodies. It turns out that there's a field called the neurobiology of gonadal hormones, and it's basically the effect of estrogen and testosterone on brain development and on brain activation during adult life. So our brains, just like animals, just like birds, for example, every spring, the male bird develops new neurons. This has been known since the 1970s, under the influence of testosterone, which codes for 5 notes, which is a bird song. And the female develops brain cells that are the receptors for those 5 notes. And that music, which is driven by testosterone and estrogen and has effects on new neurons being developed, is necessary and essential for survival of the species. It's been shown, for example, that there are differences in normal human brain development and in normal human brain function that are gender differentiated. And I say this because it provides the basis. There are estrogen receptors in the brain. And so we used to think that this had a long-term risk on the development of dementia. And I actually conducted one of the first clinical trials back in the early 80s of estrogens for postmenopausal women who had Alzheimer's disease. And this led to a large number of studies, such as the Women's Health Initiative, which looked at whether estrogens themselves could be used to treat postmenopausal women with dementia. And it turned out that, in fact, postmenopausal estrogens, when they were started after 65, increased the risk of stroke and was a bad thing. So then we turned to what's the difference at the menopause. So just like women at the time of menopause develop osteoporosis, that rapid decline in estrogen, in ovarian failure that leads to estrogen loss, has an effect on the bone that leads to osteoporosis. And there's that critical window in the first year or 2 after the menopause when we can prevent that bone loss and prevent osteoporosis, so we don't have little old women anymore. That's not a normal part of aging. The theory right now is that maybe the same thing is happening in the brain because estrogens are required for what we call tropism in the brain. And so there's a lot of work going on now around the time of menopause. Maybe that's the scientific basis for why women have a greater risk. And the last thing I want to say is, one way to look at that is with the incredible advances in neuroimaging. And what we're starting to see is that around the perimenopausal period, as estrogens are declining rapidly, women who don't take any estrogen are starting to develop amyloid deposition on the PET scan that I mentioned earlier. And the women who take 17-beta estradiol, which is the normal estrogen that women have, prevents that production of beta amyloid in the brain, which is the earliest signs of Alzheimer's disease. So from a scientific point of view, there's a lot of scientific basis for this that goes back 40 years. What we're trying to do now. But
you wouldn't argue that we've spent too much time studying sex-based differences or differences based on ethnicity or race, correct?
Well, we haven't.
I know one of the things we're trying to do is encourage more people to be part of clinical trials, which really helps with what you were saying about early diagnosis. And one of the things, and I know we've talked about the disparities of, how do you encourage more people to be part of this research so we can learn more?
Right, and women generally are. It's usually we in the clinical trials it's about 50-50.
Now it is, okay.
So it's not and often it's 60-40. You know, women are definitely involved in trials. But I think one of the things that's come up recently, for example, is that one of the gender differences in brain function relates to verbal memory. And so it turns out that women that have a thing called a diagnostic syndrome called mild cognitive impairment, which is the precursor to dementia, actually often have better verbal skills at the same time that men are developing memory loss. And so it makes the diagnostic subtleties of making a diagnosis of Alzheimer's disease gender differentiated, and that affects how women get into clinical trials also.
Great. Well, that's really helpful. And George, I know Us Against Alzheimer's has really worked hard to promote more research and funding at the National Institutes on Health. I know Linda, when she was at HHS, we were all part of really increasing that budget at NIH, and that's really important, and we need to see more to that. But more recently, you've started to focus your attention to look more at brain health and some of the interventions that we can do today, what we know and don't know. Why did you feel a need to focus more on brain health?
Well, my organization, one of the things we've learned over the last 10 years in all these trials is this disease starts pathologically in your body 20 years plus before symptoms ever appear. So if you think this is a disease of 75 plus, it actually starts in your 50s at least, and maybe earlier. So one of the things that has led to, it's called shifting left. So if you think of the dial of early disease to late disease, we're shifting left. That means that we're looking for drugs that would intervene earlier in the course of the disease to slow the disease down, so that if in fact you give this to someone at the very beginning of mild cognitive impairment, maybe you could slow the disease down and not have late symptoms, because people die at the same time, but they'd never reach late stage. They die of something else. Or if you could give a disease-modifying drug to somebody before symptoms appear and slow the disease down, maybe you could prevent symptoms from occurring. Well, what if you look at all the work that we did, advocate for greater research spending at NIH, the development of a venture fund called the Dementia Discovery Fund, which invests in novel approaches, a clinical trial network that we've set up. We did this because we wanted to de-risk the process by which a drug got to patients. Well, if you think that the disease-modifying drug is the way that the industry is going to go, at least in part, you need to diagnose people much earlier in the course of the disease than doctors tend to do. You have to get them not to think, gee, your memory may be fading, let's see how it is next year. Exactly the wrong thing to say. So what we said to ourselves is, okay, to the industry, you're going to need a big audience, a big market for your disease-modifying drugs. We have got to go earlier in the early in the disease process to get you diagnosed earlier. Well, that led us to think, how do you begin to talk to people about their brain health at a time when you're not necessarily talking about diagnosing Alzheimer's? Because the conversation, if you look at, we did some polling, if you go out and you say, how interested are you in getting an earlier detection of your of Alzheimer's? No, thanks, really, you know, some people say yes, but a lot of people say no. How interested are you in learning what you can do during the course of your life about improving your brain health? Put my hand up for that one. So what we started thinking about was, okay, what's the science of brain health? What is the existing science telling us, at least the promising emerging science telling us that in fact you might be able to do earlier stages of your life before you probably are going to get Alzheimer's, to actually talk to people about their brain health. And then begin to get physicians to talk about those things that come naturally. Diabetes is an aggravator, cardiovascular disease and hypertension midlife, that's an aggravator for dementia. Let's get the doctors to think about that in the context of also improving or at least delaying or deferring potential decline to dementia. Sleep disorders, sleep apnea, that's a problem because your brain tends to clear these toxic proteins during their night. So let's talk about sleep. Those are things that doctors probably could talk about in the normal course of practice. So that's stage one. Begin to get doctors and physicians, OBGYN as well as primary care physicians more generally, to talk about brain health in terms of comorbidities or co-occurring diseases that might be aggravators.
Sort of meet people where they are, or where they're going to see their physician.
Where they are. And then lifestyle. We now begin to see some studies that suggest that, in fact, you can change your lifestyle in ways that will actually diminish your risk for dementia, at least a significant portion of the population with dementia. So shift to brain health and not just talk about the dreaded Alzheimer's.
Great, thank you. And I want to go back to the question of Medicare and Medicaid and how, you know, those of us who've worked in the government or outside the government have pushed to have Medicare cover these cognitive screenings and many preventive services and screenings that are completely free to the beneficiary, but they're really not taking advantage of it. And I think this is a combination of some of what George said. I think studies that we've looked at have said physicians don't really want to talk about it because they're afraid to give the diagnosis. They don't know what else they can tell their patients to do. People who fear they have symptoms of dementia, they don't want to know because it's a real financial risk. If you get diagnosed with dementia, you could lose your job. Someone could take away your car keys. Someone could say you can't have this independence. So there is this fear of having that. And I just want to ask you, Linda, what do you think, why do you think just paying for the screening, as someone who's worked closely on both Medicare and Medicaid, why is that not enough?
A lot of it does have to do with then what. And so if you look at certain other preventive screenings, when there have been more effective therapeutic interventions, the screening has gone up sometimes, but it hasn't gone up immediately because there's still stigma, fear, denial, all of the above. Behavior change is terrifically hard. And that speaks also to some of the lifestyle changes. I mean, even with this information, I think we're pulling together more and more compelling reasons for people to exercise and stop smoking and eat well. And yet we're still not where we ought to be in terms of people taking up those behaviors. So it requires quite a lot to get over some of those entrenched habits and some of the psychological barriers, both on behalf of or on the part of the people seeking care and sometimes on the provider side as well.
Great, and Norma, did you want to jump in and talk some about any of your? And again, I ask everybody just to jump in but as you've looked at some of the economic differences between populations and what might be some barriers to even going to the doctor, for example.
Yeah, there's certainly differences in access to care, but also let's not forget, if we're talking about a major screening program for something like dementia, we have to have the workforce in place in order to do it. We need to have the PET scans available and ready to go, and screeners who are trained to read these PET scans. And so there's scaling up is a huge issue. And if it's not 100% definitive and there's nothing we can do about it, it's going to be really hard to make sure that we have the workforce and we have the technology ready to go, because no one knows what to do with the information once they get it.
This drives me crazy. I've been taking care of people with Alzheimer's disease and their families for 40 years. And when I hear somebody say there's nothing you can do, my response is, what do you think I've been doing for the last 40 years? And I think, in this context, I always quote Hippocrates, who said about a couple of thousand years ago, the role of the physician is sometimes to treat, often to relieve pain, and always to comfort. And when we talk about there's nothing to do, it's true. We don't have treatments, specific pills that we can take that will be affordable yet. But we do need to take care of these people. And I can give you plenty of examples where undiagnosed dementia leads to not only bad outcomes, but costs. One example is my father, who had insulin-dependent diabetes from the age of 55 until 85. And he lived in a one-bedroom apartment with his wife. And he was an engineer, and he used to use his slide rule, and he had graphs and everything, and he was never admitted to the hospital. Okay, and when he got dementia, which had been undiagnosed, he was admitted to the hospital 4 times in 1 year with ketoacidosis, which is diabetes completely out of control. And he used to get up in the middle of the night, and he didn't remember if he took his insulin, and he would he would give himself the insulin. And this happens over again. And actually, I think there's a lot of data that there are excess hospitalizations in Alzheimer's disease, which are a driver of Medicare costs. And so, and most people, 50% of people get diagnosed by physicians at the stage of moderate dementia. This is a stage where they're starting to have trouble tying their shoes. This is something they learned when they were 5 years old. Now they're 85 and they can't tie their shoes, and they don't know how to prepare a meal or go shopping or, you know, do the laundry, or they're at risk for falls and these kinds of things. So the idea that early diagnosis is not necessary because there's no pill for this disease yet drives me crazy, because patients and families, first of all, they appreciate a diagnosis so tremendously because they come in after a year of wandering around trying to understand what's going on with their loved one. And then we make a diagnosis and they say, now I get it, what can I do? Okay, well, this is the plan of care. This is how we're going to protect you. And the thing is that doctors really aren't paid to do the kind of hour-long, that's what it takes me. And I know that's why I get a lot of referrals. So I think there's a lot we can do, and there's a great rationale for early diagnosis. And I just want to make one more point if I can.
Go ahead.
There's a difference between screening and making an early diagnosis.
Yes.
Okay, so screening has to be cost effective. And when, let's say, 2% of the population at age 60 has cognitive impairment versus, say, 30% of the population at age 80, screening at age 80 might be cost effective, but screening at age 60 or 65 may not be cost effective. There are programs out there that have done screening in places like CVS. We have depression screening in pharmacies. We have blood pressure screenings in pharmacy. There's a lot of stigma against memory screening in pharmacies and what the value of that is. But it's been done in about 100,000 people in many sites around the country. As long as was mentioned, that the screen failure people, the people that don't pass the screen, there's a process for linkage to a doctor who can help with the diagnostic evaluation, because about 10% of the time there are reversible causes.
And what are some of those things? I know, George, you've been focusing on, you know, what is the evidence on the non-pharmacological interventions or lifestyle approaches that we can take? Does the NIH, are they buying this?
Well, NIH now has 58 non-pharmacological studies. They only have about 30-some pharmacological studies. So they're investing heavily in the space, not surprisingly, because there's not much IP, intellectual property, in the non-pharmacological space, so industry is not necessarily as incented there. But yes, they are studying this hard. And the Mediterranean diet has been demonstrated to have a modest positive effect, yes. Aerobic exercise, yes. A Sprint Mind study recently concluded that those people at risk for cardiovascular disease with high blood pressure, if you get their blood pressure down to 120 over X, in fact, there is a significant, roughly 20% reduction in the incidence of MCI and potentially follow-on reduction in the incidence of dementia. There's a study in Europe called the Finger Study, which was a lifestyle intervention study of multiple lifestyle changes, carefully monitored, so it may not be a population health strategy, but carefully monitored, that demonstrated a significant positive impact on cognitive decline. Positive meaning less cognitive decline. But these studies are just the forerunner, I think, of a lot more studies in this space. While the Lancet Commission in England concluded that potentially up to 35% of the cases of dementia may be preventable through 9 different lifestyle interventions: midlife hypertension, midlife obesity, hearing loss, late life depression, a number of others. So we have, and on the National Academy of Science in the United States, they said, well, there's some emerging evidence that maybe. So we have a slightly different, a little more optimistic position in Europe and a little more conservative position in the United States. But the science is emerging in this space that there's something there. Great challenge is what it is, what combination of factors are they, and how do you get something that actually can cause people to change their behavior? Because we know that we've done this in heart, and we know that there is a lifestyle change that has helped in heart and cardiovascular disease. We think there is one in dementia as well, but we have to have a good deal more studies, and we are studying it. But there is a good deal here that says that attention to your brain health can mean an awful lot. So you start with some of the comorbidities, and I agree with Howard. The data is that a person in Medicare with comorbidities, diabetes and cardiovascular disease and dementia, versus a person in Medicare with just cardiovascular disease and dementia, cardiovascular disease and diabetes. The person with dementia is 3 times more costly to Medicare. So why? For precisely the reason that Howard laid out with his dad. People who have some other condition that is life-threatening forget to take their medicines or to perform whatever it is that they had been advised to perform because they've forgotten it. And so, yes, it makes a difference that we diagnose it early and that, in fact, the doctor is attentive to the compliance issues with other comorbidities at the very least, and probably lifestyle interventions as well.
So one of the things we're focusing on in our update of the paper, and I know that many of you all have looked at, I want to get to the community-based resources in a second, but I also want to think about the dementia-capable workforce. And as you said, you're frustrated if doctors say this, that they should know this. I know, Linda, we've worked about, how do we get the information about the supportive services that are available so they can let people find these information. As you're on the ground, encouraging people, helping families who are living with dementia or have that diagnosis. What community-based resources, home and community-based resources are really helpful?
So there are a number of non-clinical components to addressing this issue as there are for any number of our health issues. So if I could back up for just a second. Only about 20% of our health is dictated by clinical care. So much of it has to do with other pieces, the social determinants of health, where you live, the environment that you're in, the trauma you may face. And so for people who are dealing with particularly challenged lives, they have a higher burden that they're operating with around stress, around comorbidities often. And so looking at this problem, obviously we have to be very targeted, looking for an intervention, looking at the pipeline, and at the same time, we need to be looking at the environment in which people live, work, play, so forth, because that also has huge impacts on their outcomes across the lifespan, not just for children, but all the way, the whole lifespan. So community supports are incredibly important, and it's another area where George brought up an international comparison where we could take some lessons around bringing healthcare and social care together, or health and human services together for people in such a way that we are able to support them more fully so they can have the best health possible for them at whatever stage they are. True health equity. Everyone's not going to be the robust picture of health, forever and ever, amen, but we can give them something, to help them be at their best functioning. So that's one piece of the community, or that's an overview of the community. One community resource that's available, you have area agencies on aging, for example, that really do a great job often of connecting people to resources in the community to support not just the person with dementia in this case, but the caregiver as well. Respite care, support groups, connecting.
So I just wanted to ask Norma, so, thinking about what you found about the enormous costs on informal care and what we could do, what are some policies we might be able to impact to help people in this, so that they're not so economically burdened?
So I think that there's hope and a lot of potential there. I think the technology is such that we can now do remote work, we can now do different types of work, and so we can keep engaged in the labor market instead of having to drop off completely in order to take care of someone. I think there's also just technology in the house that allows us to help keep someone in the home without having to monitor them 24/7 on site. We have videos, we have smart homes, we have interventions like that. But also, I think, we can look abroad and we can look internally for long-term care insurance type options. The insurance market itself has basically disappeared. We've gone from 125 companies selling long-term care insurance about 15, 20 years ago. We're down to less than 15 now. So I'm not saying we have a private market that's working well, but we do have other alternatives. We can look abroad. Germany instituted their own plan within the last 20 years and has been quite successful. The state of Washington passed something just last week in order to have their own long-term care trust act in place. So I think that there's a lot of attention, at least, and so there's a different ways you can finance it, but there's a lot of attention to the need that we have for something to provide long-term care before Medicaid kicks in. Medicaid's a great insurance product, but it's basically at the cost of everything that you've saved up until that point in your life. And so, having something in between that allows people to keep working, allows people to get the help that they need, and still stay in the community if that's what they want to do and can do, seems like a good opportunity now to have that conversation.
That's great. And we really are starting to engage in that conversation in the Milken Institute. Many of us have worked on long-term care for a long time. It's like beating our head against the wall. But I think there really are some new ways of looking at how we can bring these things together. So it's the insurance products also bring in what are the interventions we can do to help reduce people's risk? What are technologies that we can use to help the burden? So that's a great discussion, and we could spend a lot of time thinking about that. I know my friend Bob Kramer here just released a paper looking at the forgotten middle, and I think that is a challenge in the United States in particular, that we have programs for the poorest in our population. Those who are wealthy can provide paid services, can buy those services and stuff. It's the people in the middle who have very little savings, who have no housing, et cetera, that we really need to be focusing more. Can I
pick up on something
yeah.
that Linda said, comparisons to other countries. Japan is obviously a country now where the significant aging factor in terms of the demography is much more significant to their society than here, because they have not been the beneficiary of immigration, which we have over the last 50 years. So as a consequence, their society is almost upside down in terms of the aging population versus the younger working age population. So what are they doing? They have now committed as a country to a strategy that says, using brain health as a strategy, they are going to aim to have the average life expectancy be 100 years old, where your brain span equals your lifespan. Now that's a different way of looking at this disease rather than trying to cure something or trying to do this or that. It is, what's the goal here? Mm-hmm. We're trying to live longer and healthier lives. We've had this great success in the 20th century with doing that. So how do we confront a world in which most of the diseases are not now curable or treatable as a result of better drinking water or better air or a variety of interventions, public health interventions? So they as a society have said they treasure their older populations, and so they want to grow their older population, not think of them as dependents. So they're building an industry around how to support people who may be frail or demented. Robotics is aimed at this population, is a huge component. Driverless cars, a huge component. Building real estate in cities and buildings in a way where you co-locate the services that you need, a big industry. So we had a corporate conference in Japan. Here it would have been the pharma companies. There was real estate companies, 2-hour delivery service companies, driverless car companies, real estate companies. It was a completely different way of looking at the population, not just as aged, infirm, how do we care for them? It was, how do we make them healthy? And how do we drive health into this conversation and drive what we've succeeded in doing in the 20th century, getting people to live from age 31 globally now to the 70s to drive it to 100. So it's a much more positive way of looking at the
Absolutely, and I want to get to the positive. I also want to make sure I have time for some Q&A from the audience. So if someone on my team could let me know when we only have 15 minutes left, I really appreciate it. I know, Howard, you wanted to jump in, and I do want to make sure we touched a little bit about what's happening in drug discovery. But did you want I would just say the Center for the Future of Aging at the Milken Institute has really been looking at these issues for a long time. The longevity economy is what George is describing, that he said in different places around the world, they really see the aging population as an opportunity, not only for providing products and services, but also recognizing that older people in the communities are an important part of economic growth, of the potential there, and how to make sure that we have workforce to support, but also to employ older workers. But Howard, before we turn to the science, do we want to jump in on this question?
Yeah, well, another way of looking at, I think what George said, and it's always been the goal of medicine, and particularly geriatric medicine, is, not the old saying, not to add years to life, but life to years. And there have been studies that have shown that if take the average life expectancy to be about 80, and if we could delay the onset of Alzheimer's disease, which is around 75, by just 5 years, we would reduce the number of people with Alzheimer's disease suffering loss of cognition in old age by 50%. So that's in my mind, that's an achievable goal, both through prevention, where we delay the age of onset of Alzheimer's, but also through the development of drugs. And so right now we have over 100 drugs in clinical trials. Only 25% of them are actually on this anti-amyloid approach, which has failed recently.
Right, and just on that, so I know I've talked to Mark and to you about, the big Biogen announcement really made some people shudder that we put all of this research and money, and now, do we have to go back to the drawing board? But you've been studying other approaches for a while, correct?
Yeah, well, our foundation has been funding drug discovery and development for almost 20 years now, and we've seen over 6,000 ideas for new drugs. During that period, we funded 600 drug discovery and development programs in 18 countries, deploying about $130 million. We have 25 clinical trials going on. And of the 25 clinical trials that we're supporting now, none of them are directed against the amyloid target. Which we stopped funding about 7-8 years ago when Big Pharma took on the tremendous cost of running trials in Alzheimer's disease. A single phase 3 clinical trial in Alzheimer's costs somewhere on the order of $300 or $400 million, and you have to run 2 or 3 of these just to get an FDA approval. Biogen risked $3.2 billion in their amyloid program. But I think that what we've had to do, like I said, I ran one of the first clinical trials in Alzheimer's disease in the early 1980s. And when I think back about what I did back then, I realized we had very little idea what we were doing. If you think about how cancer has evolved, they've had to learn how to do clinical trials, and so have we. And the Biogen study failed, but in some ways it was a very successful trial for a couple of reasons. One is that the drug actually worked. It did what it was supposed to do. It was the first time that 100% of the people who went into that trial actually had Alzheimer's disease, and they had amyloid in the brain, which was the target of the drug. And that was due to this PET scan that I've been talking about that detects the amyloid. So that was a big change in the way we do clinical trials. The second thing that the trials showed was that 80% of the people at 18 months had complete removal of the amyloid from the brain. So they showed that the drug actually worked. It had its target, and it removed the amyloid. What unfortunately, this amyloid hypothesis was that if you remove that misfolded protein from the brain, people are going to get clinically better, and they didn't. So it may have, there's still a couple of trials going on, but what it has done is it's taught us, through our work in running many clinical trials, we've learned how to do better, more rigorous, efficient clinical trials. George is doing work in setting up platforms around the country. Platforms are being set up just like the NCI set up, the National Cancer set up platforms for Alzheimer's clinical research. But what we're doing from a scientific strategy point of view is the leading risk factor for Alzheimer's disease is aging. And what we've failed to do is translate all the knowledge that we've gained over 100 years of research on the biology of aging and translate that into new therapeutics. So, for example, neuronal energy failure, which is related to insulin resistance in the brain, epigenetic changes in the DNA of patients with Alzheimer's disease, and all of us as we age, vascular changes that can be targets for Alzheimer's disease, an approach called neuroprotection, where regardless of the multiple hits that we have as we age, that we're able to engage the cell's natural processes for protecting it from cell death.
And I want to make sure we have time for audience questions, so we're going to just put up your hand. We'll try to get to as many as we can. And I'm going to give each of the speakers at the end an opportunity to talk about what gives them hope. Howard has gotten us started on that. I did want to make sure that I also plug, as Linda and George and I were talking about earlier, dementia-friendly communities that are happening all over the world, really. The UK was a leader in this, Australia. The United States, we launched it as part of the White House Conference on Aging on 2015. And what we were talking about is how focusing on brain health at the early stages of life is critically important. But there are things you can do even after you're diagnosed with dementia that can really increase your brain health and your independence and your opportunity to work in the community. So do we have any questions from the audience? Okay, this gentleman back here. Falls prevention is our next.
Thank you all for your time to talk about this very important topic. I had one question for the scientists on the panel. I recently read an article about a gentleman named Dr. Paul Cox, who's doing some research on L-serin that kind of goes against all the amyloid stuff, and just want to know if you have any familiarity with that or what your thoughts are on that.
Yeah, thank you for that question. So we have a website called cognitivevitality.org. And the purpose of the website is to evaluate from an evidence point of view in a credible and understandable way what supplements are all about. I have patients who come in with literally carry-ons full of supplements that they're taking. And, you know, people don't understand evidence. For example, I can prove to you that bread is bad for you. And the evidence which appeared on the front page of USA Today was that a study showed that 95% of all felonies are committed within 24 hours of eating bread. Okay.
Wow.
So so what we try to do is try to explain people the level of evidence, in vitro, test tubes evidence, animal model evidence, clinical evidence from observational studies, randomized trials. When you hear that wine, resveratrol, wine is good for you, what's the evidence? And so we have over 150 reports on that, and one of them happens to be L-serine. And so I would refer you there. But the evidence for L-serine is very poor. It's safe. People take it. You can buy it in GNC and other stores. But there's very little evidence that it works. It's a theory that it works, but the evidence is not there. And I think it's very important.
Great. I know, Carrie, you have the...
Yeah, thanks.
Great.
Carrie Kennedy, Robert F. Kennedy, Human Rights. I'm wondering how we in this Milken audience can help each of you in what you're doing. Thanks.
Great. Well, that's a nice
I'll try that. First, I would say talk about this disease. Don't be afraid of it if it occurs in your family, to talk about it. Talk about it to your friends and your neighbors, and to get your loved one who may have the disease into social situations. Don't pull them out. Don't be afraid of the disease. It is a disease. It's not a lack of character that your loved one may have the disease. It's a disease, just like cancer used to be unmentionable. Mention it. The second is get engaged. Do things. You can join a walk in your community. You can participate politically. We have usagainst-alzheimers.org has something you can do virtually every week in terms of affecting the politics of this in Washington, not just NIH spending or investment, but that's one of them, but also other policy changes that we're trying to get with Medicare to get earlier detection built into the way that Medicare thinks about this disease. And finally, support us against Alzheimer's.
Okay, George, we're going to...
No, let me just finish this. I got into this because my family got affected by the disease. So 2 other families and mine got together into a patient-centered organization. I'm a retired businessman, not a scientist, it's quite clear. But in fact, resources are important. To be able to de-risk an entire industry takes time, takes resources, takes passion, and a sense of urgency and a sense of disruption. But it takes resource.
Absolutely, and I just want to let Linda and Norma respond to that question as well. I think their resources are certainly part of it, but we want all of you to be part of this solution. There are many things that we're all working on together, which we can share that information after, but I also want you all to reflect, what do you think would help most?
I think CEOs and companies that if you're thinking about parental leave, also think about elder care leave. It hits the same people or slightly older ages, and it's just as important, if not more important, given the fact that you're going to be missing out on your prime earning years at age 60, women are more and more likely to be the sole breadwinner in their family or the primary breadwinner in their family if they are married.
Can I just interject for a second, because that's good. Let's get employers to do that. But what about paid family leave, like they're doing, in Washington? And one of the things I've advocated for, so the audience knows, the United States is the only developed country in the world that doesn't have paid family leave. So I feel very strongly that that would help, especially people who don't have employers that offer benefits at all. There are many people that don't have that. So they don't risk their income because they have to take care of their family.
But the thing is, the course of chronic care in Alzheimer's is anywhere from 4 to 7 years. And that's the real problem. The average stay in a nursing home today is 2 years. 90% of people in nursing homes are women, mostly spouses.
I understand, but people need time just to take them to the doctor.
There's absolutely, but and
we've
totally
actually
agree with
done
that.
simulations where we show that unpaid family leave for a much longer duration than FMLA could actually increase the number of women who are willing to do this and be informal caregivers, and it increases the chances that they stay on the job or return to the job afterwards. And so that vastly diminishes the cost of informal care if we can keep women working while they're doing it.
But what percentage of people who are caregivers are women in working age?
About 40%.
Okay.
So we want to keep it on a hopeful, and no, it's fine. I was just doing my advocacy, and I don't want us to debate the policies because we're almost out of time. So I just want to make sure that we have enough time to take one more question. And I'm going to let everybody on the panel, you think now quickly about, what gives you the most hope as you go forward. But Linda, I'll give you the opportunity before we take one more question to address Carrie's great question of what can they do to help?
So from whatever space you operate, to understand the huge gap that we have in our long-term care system and look at approaches to dealing with that, because these other things are very important, but without that coverage, we're going to not be able to hit the target.
Great, thank you. I think we had one more question back there. Someone with the mic, go ahead.
Thank you very much. So if early detection is important in aiding the problem that we all have that we're dealing with, the doctor mentioned a PET scan, because that was you have to send someone out to do a PET scan. My question is very simply this: in light of all the technology that's going on and that's being discovered, what else is out there other than a PET scan to detect the early stages?
Well, again, the PET scan would be part of a diagnostic evaluation. Somebody comes in and they have memory problems. You want to know what's going on. The first question they'll ask are my memory problems part of normal aging? And we know memory declines with aging, or do I have the earliest stages of Alzheimer's? That's very difficult for a primary care doctor to distinguish. You need 6 hours of neuropsychometrics over a 2-day period to really get an informed opinion based on pure neuropsychological evaluation. We can use MRI. A lot of insurers and Medicare will pay for an MRI, and there are computerized programs now that lay on top of the MRI machine as software that measure what are called volumetrics. So we know that the specific part of the brain where Alzheimer's disease starts, called the hippocampus, shrinks at about 0.4% a year. In normal people, our brains shrink about 0.4% per year. But in Alzheimer's disease, it shrinks about 4% a year. So we can use these volumetric software programs that sit on top of the MRI. And that is paid for, and that can be very helpful diagnostically to tell me that there's neurodegeneration going on. If I want a specific diagnosis of Alzheimer's disease for whatever reason, especially if people have the genetic risk of ApoE4, which we haven't spoken about, but is another widely available test, I would then send them for a PET scan. But the PET scan right now is not being paid for by Medicare. I think it should be. I think the studies that Medicare has funded of 19,000 people will get to payment. But again, the thing is, in 3 or 4 years, we're going to have a blood test. And the blood test is going to change Alzheimer's disease and care and research the same way that cholesterol changed the face of heart disease.
That's very helpful. So we're going to end where we began. Norma, so what gives you the most hope for the future?
So I mean,
but on the hopeful side.
on the hopeful side, I'm super hopeful that science will cure this or at least delay the onset at some point. I guess it's slightly different on hopeful and just on the time period. But I do think that we are having the policy discussions that are super important at this point to help current caregivers and ones that are just on the cusp, that before science sets in, we have Washington, we have Hawaii, we have other states who are trying to take a stance and provide this long-term care to help families with Alzheimer's.
Linda.
I think as a society, we are more comfortable talking about brain diseases in many different ways than we have been in the past. And I think that greater comfort will allow more folks to step into the space to address them, more folks to step up to say they need help, and will just move us along more rapidly.
Howard.
Yeah, I've been doing this 40 years. When I went to medical school in the 1970s, I never heard of Alzheimer's disease. It wasn't in my textbooks. I never made the diagnosis when I was an intern or resident. It wasn't until 1980 that I first became aware of Alzheimer's disease. When I started in Alzheimer's disease, there was no research going on. I mean, it's hard to imagine, but there was no research going on in the Alzheimer's space by 1980 when I started. The National Institute on Aging was established in 1975. At the time that we were having billions of dollars being spent on the war on cancer and heart disease, we spent $600,000 on Alzheimer's caregiving research. So from my perspective, professional lifetime, we've gone from a time when we knew nothing about this disease to a time when we have FDA-approved diagnostic tests, we have over 100 drugs in clinical trials, and we know how to do prevention. And so for me, we're in an amazing world.
That's great. George.
Well, I'll adopt everything that Howard just said, but I'm also excited about this whole notion of brain health. And I do think we issued a paper today called Creating the Optimal Brain Health Care System in America. And it has a variety of steps that need to be taken in order to empower providers, consumers, and policy change to actually make brain health an element of our standard, routine way we think of health. And to make an annual brain checkup routine as a checkup. I'll use a phrase that Patrick Kennedy taught me. Make a checkup from the neck up as routine as a checkup from the neck down. All right? And if we do that, we will begin to understand at a human level how to get people to think about their brain health during the course of their lives, whether it's treating other core-related diseases or whether it's lifestyle changes. And so if I have one last question, an answer to an earlier question, bebrainpowerful.org. Bebrainpowerful.org is the key to unlock all of this.
Great, and I know, so we're ending at 3:30, correct? Because I thought it was 3:45. Okay, so there's a lot of information here. We're so glad you're all here. We're going to be working together. As we said, the Milken Institute is launching a new project looking at dementia. We'll be working with all the experts here, as well as we want to talk to all of you all. This is just the first, as many of us have been working on this a long time, but it's a very hopeful time. So we thank you for coming. Please join me in thanking our panelists.
Thanks.